We all want good healthcare, right? I mean, that's a given.
Absolutely.
But figuring out what good actually looks like, comparing different hospitals or clinics, well, that can feel like trying to solve a really complicated puzzle sometimes.
It really can. It's complex.
Okay, let's unpack this because we're about to take a deep dive into a fascinating tool that helps bring some clarity to that puzzle. It's called benchmarking.
Exactly. And this deep dive, it's really focused on how healthcare services actually measure their performance.
Right.
And, maybe more importantly, how they use this process, benchmarking, to drive real improvements in the quality of care they provide.
And we've gathered a really great set of resources to explore this today.
We have.
We've got articles that give us the broad view, benchmarking in healthcare generally.
Uh-huh.
Then there's this super practical guide from the Ministry of Health in Bhutan. It shows the step-by-step of how it's actually done on the ground.
Really useful, that one.
And we even have insights into national quality assurance standards. These are kind of like the benchmarks that everyone aims for.
That's a good way to put it, yeah. The target.
So our goal today, our mission for this deep dive, is to really get to the heart of benchmarking.
What are the key ideas behind it?
Exactly. And how do those ideas get translated into action? Action that makes healthcare better for everyone.
Let's do it.
So let's get right to it then. In the context of healthcare, what exactly is benchmarking? Can you break that down?
Sure. At its core, benchmarking is basically a method for continually improving the quality of services.
Continually improving.
Think of it as a way to become more efficient, maybe manage costs more effectively,
Uh-huh.
and ultimately deliver better care. The fundamental principle is comparison.
Comparing what?
Comparing your own performance data, maybe within different parts of your own hospital, or maybe comparing yourself against other similar hospitals or clinics.
Okay.
And the whole point is to identify what the best practices are, who's doing it well, and how.
And how do you even start to measure this performance? It can't just be a feeling, surely.
No, you're spot on. It can't be just a gut feeling. That's where quality indicators, or QIs, come in.
QIs.
Yeah, QIs. They're essentially simple, measurable tools that give you a clearer picture of the quality in a specific area of service.
Okay, like an example.
A really easy one to grasp is waiting times. Say, in outpatient departments, OPDs.
Right, how long you sit waiting.
Exactly. How long do patients actually wait to see a doctor? That's a direct, measurable indicator of how that part of the service is functioning.
So if those waiting times are consistently long, that flags something important.
Absolutely. And what our sources really highlight is the need for these indicators, these QIs, to be accurate,
Of course.
reliable, and efficient. They need to be useful for the people on the ground, the staff.
Useful how?
Well, if the staff can easily understand the data and see how it connects to their daily work, they can then use it to develop concrete plans for improvement.
I see.
But if the data is, say, really hard to collect, or it doesn't measure something truly meaningful, well, then it probably won't lead to any real change.
Right, it just becomes numbers on a page. Now, this manual from Bhutan you mentioned, it seems to provide a really hands-on guide to setting up a benchmarking system. What are the actual steps involved?
Yeah, the manual outlines a very practical, step-by-step approach for monitoring these quality indicators.
Yep.
The very first step, and maybe the most critical, collecting the data.
Getting the raw information.
Exactly. You need good, reliable information to be able to make useful comparisons, both comparisons over time within your own facility
Tracking your own progress.
and when comparing yourself to others.
Mm-hmm.
And the manual emphasizes using existing key performance indicators, or KPIs, whenever possible.
That makes sense. Don't reinvent the wheel if you already have relevant data points.
Precisely.
But what about new information? What kind of things might they recommend gathering specifically for this?
Well, they specifically suggest using patient satisfaction surveys.
Asking the patients directly.
Yes. Both for patients who are just visiting the outpatient department, the OPD,
Right.
and also for those who are being discharged after a hospital stay, the inpatients.
Okay, two different groups.
And the manual even includes example questionnaires in the annexes. They cover things like, how long they waited, how well the doctor communicated, the cleanliness of the facilities, their overall satisfaction. It's quite detailed.
What about the staff?
Good point. They also recommend surveying staff because their perspective on quality, what's working and what's not from the inside, that's crucial too.
So you get both sides.
Yeah, getting feedback from both the recipients and the providers of care gives you a really well-rounded picture, a 360-degree view almost.
So you get all this feedback, all this data waiting time, satisfaction scores, staff input. What happens next? How do you start to make sense of it all?
The next stage is all about organizing and analyzing that information, making it usable. And the manual gets quite practical here, even giving advice on using spreadsheets for this.
Spreadsheets, okay, like Excel.
Exactly. They specifically mention entering the data and then using a particular function in Excel called COUNTIF.
COUNTIF. Okay, that sounds a bit technical maybe for some folks. Well, what does that actually do?
It's actually simpler than it sounds. Let's go back to our waiting time example.
Okay.
Let's say your target, your goal, is to have patients wait less than 30 minutes.
A common goal.
Right. The COUNTIF function lets you automatically count how many patients in your collected data actually met that goal, how many waited under 30 minutes.
Ah, okay. It just counts them up.
Precisely. The example formula they provide is COUNTIF B5, B69, 36. So if your waiting times for, say, last month are listed in those spreadsheet cells, B5 down to B69, this formula will instantly tell you exactly how many fall below that 30-minute mark. We even have a visual example of what that looks like in Excel. Makes it really clear.
Okay, I think I get it. It's literally just counting the number of times that condition waiting less than 30 minutes is met in that chunk of data. So what do you do with that raw number?
Good question. The count itself is useful, but often you want a percentage.
Right, like X% of patients waited less than 30 minutes.
Exactly. So the manual shows you how to turn that count into a percentage. For example, if you had, say, 65 patients in total that month,
Okay.
and the COUNTIF function told you that, let's say, 50 of them waited less than 30 minutes.
Right.
The formula 100, B5.B69, 3065, would calculate that percentage.
So 50 divided by 65 times 100.
Yep, which
Right.
comes out to about 77% in this case. And they also stress, importantly, giving this measurement a clear and understandable name.
Not just the formula.
No, something like percentage of patients waiting 30 minutes. This makes it easy for everyone involved, doctors, nurses, managers, to grasp what's being tracked.
So now you have this percentage, a clear number. How do you actually see if things are getting better or maybe worse over time?
That's where visualizing the data comes in. Pictures tell a story, right?
Definitely.
The manual explains how to use the charting tools built into spreadsheets to show these trends visually over time.
It's like line graphs or bar charts.
Exactly. They give an example of a bar graph showing that very indicator, the percentage of patients waiting 30 months, tracked from July to September of 2011.
And what did it show?
Well, in their example, the graph clearly shows a downward trend over those 3 months.
Not good.
Not good at all. Seeing it laid out as a graph makes it really easy to spot potential issues like that. The manual even includes an actual picture of this bar graph.
Oh, really?
Yeah, illustrating this decline, specifically for what they call Chamber 3, where the percentage drops quite sharply, from over 75% in July down to around 45% by September.
Wow, that's a significant drop.
It is. And that kind of visual representation can be incredibly powerful in highlighting areas that really need attention. Management can see it instantly.
That's a really clear picture. Now, the manual also talks about regional health teams. What role do they play in all this benchmarking?
Right, moving up a level. At a regional level, these health teams can collect the data from all the different healthcare facilities in their area, all the hospitals, the clinics.
So they aggregate the data.
Exactly. They collate it. Then they can put it all together into reports and graphs that allow for comparisons between different facilities on those key quality indicators.
So you can see how Hospital A compares to Hospital B on waiting times, for instance.
Precisely. The manual even shows examples of these kinds of comparative graphs. They look at OPD waiting times, emergency room waiting times. Across different regions, they mention Western, Central, and Eastern regions. And they compare those regional results to the national average.
That sounds like a really effective way to drive improvement across the board.
It can be, yes.
I mean, if one facility is consistently lagging behind on certain indicators, the regional team can see that clearly.
Right there in the data.
And potentially offer support or maybe help them learn from facilities that are doing better, right?
That's exactly the idea.
Yeah.
The manual specifically mentions identifying facilities that aren't performing as well and providing them with targeted support for improvement.
Okay.
And just as importantly, it talks about highlighting and sharing examples of good practices that are found within the region, spreading the knowledge.
Learning from the best. Makes sense. Now, the manual also touches on different quality improvement tools. How do those fit in with this whole idea of benchmarking?
Yeah, the annexures in the Bhutan manual list a whole range of these tools, practical tools for quality improvement.
Like what kind of tools?
Well, they include things like different methods for data collection itself, brainstorming techniques for generating ideas,
Mm-hmm.
criteria matrices, which help in making decisions, flow charts to map out how a process actually works.
Visualizing the steps?
Exactly. Cause and effect diagrams, sometimes called fishbone diagrams, to understand the root causes of a problem. And then various types of charts, like the bar charts and pie charts we mentioned, but also run charts, which track data points over time to see trends,
Right.
and histograms, which show how often different values occur in a data set, the distribution.
So a whole toolkit.
A whole toolkit. These are the practical methods that the healthcare teams can actually use to dig into the issues that the benchmarking data highlights.
So benchmarking finds the what, these tools help find the why and the how.
That's a great way to put it. Understand the root causes and then develop and put into place effective solutions. And importantly, benchmarking itself is listed as one of these key quality improvement tools.
Ah, so it's both the starting point and part of the toolkit.
Exactly. Which really emphasizes how central it is to the entire continuous improvement process.
Okay, so benchmarking isn't just about taking measurements and comparing. It's really the trigger, the starting point for an ongoing cycle of improvement using these other tools. Now, let's maybe switch gears a little bit and talk about these National Quality Assurance Standards, or NQAS. What are those all about? It seems like a bigger picture thing.
It is. The NQAS serve as a larger framework for quality in healthcare. They set the bar, so to speak.
And where do they come from?
Well, they actually draw from a pretty wide variety of existing quality standards. Think of well-regarded international standards like JCI, that's Joint Commission International,
Okay, heard of them.
and IPHS, which often refers to Indian public health standards, but also national health program guidelines specific to the country, and even broader quality management frameworks like ISO 901.
So they pull from lots of sources.
Yes, the goal is really to create a comprehensive roadmap that healthcare facilities can use to improve across the board.
And what are some of the main ideas, the core principles behind the NQAS?
Several key principles stand out in the materials. They really emphasize looking at quality from all angles,
What do you mean by all angles?
considering the structure of the healthcare facility, or the resources, the building, the equipment.
The foundations.
Right. Then the process is how care is actually delivered, the steps involved,
Oh.
and finally the outcomes, what actually happens to the patients as a result of the care. Are they getting better? Are they satisfied?
Sure, process, outcome.
Got it. Transparency is another core principle, making sure the measurement systems are clear, that everyone involved understands the standards they're working towards.
No black boxes.
Exactly.
Yeah.
And finally, the NQAS are really meant to be a guide for improvement, not just a checklist for some external evaluation, but a roadmap for the facility itself to get better. The manual from that district hospital memo we mentioned even points out specifically that patient and family rights are in alignment with these NQAS standards.
Okay, so it sounds like these standards provide the overall goals for quality.
Kind of the what good looks like definition.
And benchmarking gives you the tools to measure your progress towards those goals.
That's a great way to put it, yes. And the NQAS often lead to the formation of different committees within a hospital structure. Yeah, things like dedicated quality assurance committees, disaster management committees, and others. All working internally to make sure these standards are being met and that quality is continuously improving.
Okay, that makes sense. Now, we also looked at a review of research, some academic studies, that examine how benchmarking actually helps improve healthcare quality in real-world situations. What were some of the key findings from that research? Did it actually work?
Yeah, this review gave us some really interesting, concrete examples of how benchmarking has made a tangible difference. It found that most of the benchmarking efforts that were studied were voluntary initiatives.
So hospitals chose to participate.
Right, they opted in. And they often happened at a national level, comparing facilities across a country.
And the results?
What's really encouraging is that many of these initiatives showed positive effects, both on how healthcare is delivered, the processes, and on the actual outcomes for patients.
Can you give some examples?
Sure. For instance, there was evidence of increased use of necessary preoperative medication in some surgical settings, making surgery safer.
Okay.
In centers treating patients with cystic fibrosis, those using benchmarking showed improvements in patient weight and lung capacity, real clinical improvements.
Wow, that's significant.
Definitely. Other studies reported fewer patients being readmitted to the hospital after hip replacement surgery.
A big issue, readmissions.
Huge. And a general decrease in postoperative complications, across various surgeries.
Fewer complications after surgery. I mean, that isn't just a statistic, is it?
Absolutely not.
Yeah.
That means fewer patients experiencing pain and discomfort, potentially shorter hospital stays.
Faster recovery.
Exactly. Ultimately, a better recovery and quality of life. These are meaningful impacts.
Those are some pretty significant improvements. So what kinds of actions did these benchmarking results actually lead to? How did they get from the data to those better outcomes?
The review highlighted a range of actions hospitals took. Healthcare teams would often meet specifically to discuss the benchmarking findings.
Talking about the data.
Yes, providing feedback to the different departments or units that were participating. Putting into practice specific quality improvement techniques they learned about through the comparison process.
Learning from the high performers.
Right, and even developing formal guidelines for best practices based on what the top performing units were doing.
So it really fostered a learning environment, like a collaborative effort almost.
It really seemed to encourage a culture of shared learning and continuous improvement. That came through quite strongly.
Were there any difficulties or challenges in using benchmarking that the research identified? It can't all be smooth sailing, can it?
No, definitely not.
Yeah.
The review did point out some challenges. A major one is creating reliable indicators that can be used to accurately compare performance across different countries.
International comparisons.
Yeah, that can be really tricky because different countries might have different ways of coding medical information, different ways of defining things.
Different systems.
Exactly. Different methods for calculating these indicators. So getting that apples-to-apples comparison can be tough internationally.
That really underscores how important it is to have standardized, clearly defined ways of measuring things if you want to compare effectively.
Absolutely critical. Consistency is key.
Okay. Finally, let's maybe circle back to the practical side of things one last time with the example of that district hospital MAMIT manual from Bhutan. What does implementing quality improvement and potentially using benchmarking look like in a specific hospital setting day to day?
Right, bringing it down to the hospital level. The district hospital MAMIT manual gives us a really tangible example of how a specific hospital approaches quality improvement on a daily basis.
How so?
Well, it clearly outlines the hospital's commitment to various aspects of patient care. Everything from making sure people can access the care they need
It's fundamental.
and minimizing how long they have to wait, to properly maintaining equipment, making sure beds are available, and being prepared to treat emergencies promptly.
The basics done well.
Exactly. And they emphasize using patient records, the case papers, and feedback from patients through things like exit interviews and satisfaction surveys as key ways to continuously improve.
So listening to patients.
Constantly. Which aligns perfectly with what we saw recommended in the broader Bhutan National Manual we discussed earlier.
And they also actively track specific quality indicators, right? Like the waiting times.
Absolutely. The manual lists a whole range of QIs that this particular hospital monitors, which gives us a real sense of what they're paying close attention to.
What kind of things?
We see things like waiting time at the pediatric clinic specifically, the average door-to-medicine time, meaning how long it takes from arrival at the ER to being seen by a medicine doctor.
Okay, very specific.
Very. Also, the C-section rate, how full the hospital beds generally are. That's the bed occupancy rate. The rate of patient falls, which is a key safety indicator. The number of medication errors per 1,000 patient days.
Wow, tracking errors.
Yes, tracking and aiming to reduce them. And even things like the donor satisfaction score at the blood bank.
That's quite a list.
It is. And they even include the specific formulas they use to calculate some of these. For instance, the proportion of patients attended to during the night in the accident and emergency department.
So they're really measuring things quite meticulously.
It shows a clear commitment to measurement. These are all concrete ways they're trying to quantify the quality of the services they provide across different areas.
That's a really wide variety of indicators, isn't it? Covering efficiency, safety, patient experience.
It really shows a comprehensive approach to measuring quality, not just focusing on one thing.
It does. And the manual also highlights those various committees within the hospital again.
Yes, like the Drugs and Therapeutic Committee, the Infection Control Committee, and the Death Audit Committee.
Death audit.
Yes, reviewing deaths to understand causes and identify any potential areas for improvement in care. These committees are crucial.
Why crucial?
Because they're the ones who regularly review the data related to these indicators. They identify areas where improvements are needed, and they work to ensure that quality standards, like those NQAS standards we talked about, are actually being met across all the different departments.
So they're the engine driving the improvements based on the data.
In many ways, yes. The manual even includes things like consent forms for the members serving on these committees, showing a real formal commitment to these quality assurance processes.
Right.
And we also see detailed procedures documented for different departments: emergency, OPD, inpatient wards, ICU, operating theater, the laboratory.
The whole hospital, basically.
Pretty much, covering everything from how they provide direct patient care and handle medication safely to infection prevention protocols and even end-of-life care. It really demonstrates a very structured, documented approach to embedding quality into their everyday work.
Okay. So to really try and wrap things up here, after this deep dive into benchmarking and quality in healthcare, what are the most important things we should remember? The key takeaways.
I think the main takeaway is that benchmarking offers a really powerful and, importantly, a systematic way to improve healthcare. It's not haphazard.
Systematic how?
It's a process, a cycle, really,
Yeah.
that involves consistently measuring how you're doing using relevant quality indicators.
The QIs.
Right. Then comparing that performance, honestly, to others who are doing similar work or against set standards.
Seeing where you stand.
Exactly. Then identifying the best ways of doing things, the best practices, and figuring out where you can improve. And finally, the crucial step, actively making those improvements, taking action.
So it sounds like a never-ending cycle, almost. Measure, compare, learn, act, then measure again.
That's exactly what it is, continuous quality improvement. And while the specifics can definitely get detailed,
Like the count-to formulas.
right, or choosing exactly the right indicators, making absolutely sure the data is accurate, those details matter.
Yeah.
But the core idea, it's actually pretty straightforward.
Which is
Using information, using data to make healthcare better. Safer, more effective, more patient-centered, better for everyone involved.
This has been incredibly enlightening, actually. It's really clear that there's a huge amount of thought and effort that goes into understanding and improving healthcare quality behind the scenes.
There really is.
And benchmarking is obviously a really crucial part of that whole engine. So maybe a final thought for you, the listener. Think about this. How might these same principles of benchmarking this focus on measuring, comparing, identifying best practices, and improving? How might that be useful in other areas, maybe other fields, or even in your own personal growth?
That's an interesting question.
What could you learn by systematically comparing your own performance, whatever that might mean for you, in different areas against relevant benchmarks, whether that's fitness goals, work projects, learning a new skill? It's definitely something to consider.